Hello, start.
Yes, sir. So for the first case, a 48-year-old male came with complaints of pain over the right flank region since 2 weeks. He developed complaints of discomfort and pain over the right flank, which was moderate to severe in intensity, intermittent in nature, and resolving spontaneously, which had a history of in the last 2 weeks. There was no complaints of fever or vomiting, loss of weight, loss of appetite, or altered bowel bladder habits. He is a known case of hypertension on medication since the last 10 years and had a surgical history of left chest wall abscess drainage at 9 years of age. Apart from that, no other significant surgical history was noted. On examination, he
Don't you
was
think you need
hemodynamic.
to give bladder and bowel disturbances history when you are talking about flank pain?
No altered bowel bladder habits, sir. Uh,
Don't you think
uh,
that's important when you're talking about pain in the flank region?
yes, sir.
Okay.
Yes, sir.
Does that help
Uh,
you to distinguish where the pain is arising from?
yes, sir. Like usually, if we are suspecting a ureteric calculi or picture of pyelonephritis, then patients will give some sort of altered bladder habits, or
Yeah.
even in if you're suspecting colitis or then there'll be
Yeah,
a
that's
altered
that's an
bowel habits.
important negative history that you must mention at this stage. Continue.
Yes, yes, sir. On examination, the patient was hemodynamically stable. BP was around 140 by 100 mm of Hg. Per abdomen was soft. There was no tenderness, distension, guarding, or rigidity. However, there's a vague, ill-defined fullness which is noted extending from the right lumbar to the right iliac region, and this like the surface and the margins of this could not be made out well. Apart from this, there is a 2 cross 2 centimeter reducible swelling over the umbilical region, non-tender, which is doughy in consistency, suggestive of an umbilical hernia. Also, apart from this, the patient is morbidly obese, weighing around 120 kgs.
Okay.
Yes.
Continue.
Uh, uh, After this, we did the routine
Einass,
investigate. Yes, sir.
you
Uh,
said go back to that slide. You described this, 2 by 2 centimeter reducible swelling. Why is it suggestive of umbilical hernia when you are clinically examined it? You have to be definite about, it is being it's a umbilical hernia, right? What is
yes, sir. No, sir, it is an because cough impulse is present, sir. It is an umbilical hernia, sir.
so you should definitively say that it is not suggestive. It is umbilical hernia.
Okay. Yes, sir.
Inas, you are not presenting per abdomen examination, inspection, palpation, percussion in this stepwise manner. Your summary, isn't it here?
Yes, sir.
Yeah, then
Yes,
commit
sir.
to it. Yeah, okay, continue.
Okay. Yes, sir.
Hmm.
These were the routine investigations done, which were all within normal limits. Uh, After this, like the patient came to us with a CT scan, which was done outside. The CT showed that there was a well-defined heterogeneously enhancing solid mass lesion, which was around 12.9 into 12.6 centimeter, with intralesional macroscopic fat. This was noted to arise in the right suprarenal region, associated with mild perirenal and fat stranding and fluid collection. The arterial, venous, and delayed phase during contrast showed no abnormal parenchymal findings. They also showed that renal arteries and vein flow bilaterally grossly was normal, and adrenals were bilaterally normal. Apart from this, there was an umbilical hernia with a 2 centimeter defect and herniation of momentum as content. These were the CT picture. This is the CT picture, sir. Wherein on both the axial and coronal section, we can see that there is uh, a like a solid consistency mass, which is noted, which is abutting the liver surface, and it is arising in the suprarenal region, sir, close to the IVC. And here in both of these images, the right kidney cannot be completely visualized.
Continue.
Yes, sir.
Continue.
So,
Yeah.
yes, sir. So presently, like, for further management,
Yeah. Now, Nikita,
Yes, sir.
so where do you think this mass is arising from? Going through the
Sir,
clinical
I
examination and the CT
uh,
finding. Did you get
sir,
an
the clinical
ultrasound scan? Did you get an ultrasound scan or not?
no, sir.
No,
Direct
sir,
CT
no.
was done, sir.
Uh, do you think ultrasound would have helped in this case or not?
Yes, sir. It would have helped, sir. It would have commented probably, if possible, about the origin of the uh, lesion, sir.
And
With the current picture, yes, sir. And the yes, sir. With the current picture, it could be either adrenal tumor or
Both
it could be
adrenals are normal, you
peritoneal.
said. Right kidney is not visualized.
No, sir. Right kidney is visually it is pushed forward, sir.
Where
It
is
is
it?
pushed superiorly and anteriorly. So, though they did not comment the origin of this lesion, it could either be adrenal benign mass or retroperitoneal mass,
Einass,
sir.
can you point to the right kidney in this pictures here? Where is it?
So, so like this is the entire mass, sir. So maybe it is
Hmm.
completely displacing the kidneys here. We
Zoom-
cannot make out where
It-
the right
it-
kidney is in
yeah,
the.
that's what I said. It looks like a mass from the kidney.
No, sir.
So, but you
Zoom,
can
zoom.
make out in the other side,
Which
The
this
side?
side,
Okay,
on the
okay. On the
extreme
right
right
side, the
side.
lower left corner, you
yes,
can see
sir.
the kidney.
Yes, sir.
Okay, okay. Yeah,
Yes.
okay. Okay, okay. Continue. Yeah. Hmm.
No,
So the
Nikita,
current
why did you say it is a benign tumor?
sir, because most of the content, as per the CT and as per the picture, looks like fat consistency, sir,
Then why can't
and
it
it
be a
is well
liposarcoma?
defined. Well
That's what I'm
defined.
asking. Why can't it be a liposarcoma?
It could be,
See,
sir. It could be.
retroperitoneal and adrenal, such big tumors usually will be malignant
yeah,
rather than benign.
see anything usually the cutoff is 4 centimeters, sometimes is up to 6 centimeters. Anything
Centimeters. Yes.
beyond 6 centimeters, you have to presume it is malignant unless proved otherwise.
Yes, sir.
Sir, with find
Ah.
well defined and vascularity not increased and everything, can we consider it to
Partly
be benign
looks
as well?
solid, isn't it? Enhanced with the contrast.
No,
Yes,
sir.
sir.
No,
Yeah.
sir.
Yes, sir. Solid.
A part of
Uh,
it
That is
is
solid
enhancing,
mass with
part of
fat
it looks
component.
cystic bar fat. When you're talking about
Yes, sir.
components and you want to say whether it is fat or solid, you have to speak in terms of ounce field units.
yes, sir.
Density on the CT scan measured by ounce field units. You need to talk about like that with those ounce field units. Yeah.
So
Okay.
here, look at this. It's a 12 by 12 by 12. So it's a huge tumor
Yeah.
and it is solid. So you have to presume that this has to be, malignant unless proved otherwise. It is not always necessary that it is, contrast enhancing, that it is
See,
a
you can
hypervascular tumor.
I think you can clearly define lipomas. If it is lipoma,
Ravi,
if there is
if
fat
this
component.
mass, whatever the size, if it does not take up the contrast, means it has no vascularity, means you can safely say it is benign. That's how they are concluding it as benign by the radiologist, because it is not enhancing with contrast.
So there is no neovascularization. That's what they
There is
mean.
no vascularity in this at all. There is no blood vessels going into it. So they conclude it as benign. What they are saying is correct. She's talking about the radiologist report, which is correct.
So most probably considering it to be some myelolipoma from
Yeah.
the adrenal as
Mm-hmm.
of the working diagnosis, sir.
What lipoma?
So myelolipoma, so fat containing
Myol,
myeloblastic cells.
Myelolipoma or myolipoma? Because angiolipomas are very common in kidney in the suprarenal region. So this may be a I don't think there is anything called myelolipoma. Myolipoma.
Angiolipomas
Mm,
are vascular. This
Yeah, yeah.
mass is
This is
not
not. That's what
enhancing.
I am saying. Yeah, it is
Yeah.
not an angiolipoma because there is not. It's no vascularity there.
Yeah.
So it is myolipoma rather than myelo. I don't know where is myelo coming from here.
I think
Myelo usually means from the Usually the spinal cord or something like that, no, myelo.
Sir, sorry, sir. Both actually mean the same, sir. Technically, it's a
Okay. What does
fat
the
plus tumor,
radiologist
sir.
do differential?
No, angiomyolipoma is different. Myelolipoma is different. No, it is not the same.
Angio is different, sir.
And
Myo and
uh,
myelo are same, sir. Similar.
no, usually angiomyolipoma they call, and most of them they arise from the kidneys.
Yeah.
Correct.
Yes, sir.
So myelolipoma is different. Is it the same? I don't think it is the same.
Okay, you can look into it later on.
Look
Continue.
Look into
Let's
it.
Yeah.
see.
Look into
Yeah.
it. And
So how will you manage this patient, einass? Or shall I ask Nikita because she is exam going? Is patient not a hypertensive, right?
His
No,
known case of
he's
hypertension
a
since
hypertensive.
Okay, so how will
10
you
years.
investigate this matter?
Sir, first we have to rule out whether it is a functional tumor in case if it is adrenal tumor.
Correct.
So we would like to go ahead with few investigations, sir, to rule out pheochromocytoma
Okay.
and Cushing syndrome. So we'll get
Do you
metanephrine, sir,
expect
serum metanephrine.
functionality from a tumor which is not taking contrast?
Sir, a portion of the lesion is still solid, though
Okay.
neovascular is not there.
Okay. Correct.
We can't
Correct.
100% rule out.
Yeah.
If it was only lipo component, then 100% it could be benign, sir.
Agreed.
So,
What test will you do?
so that is why
sir,
it is usually, even if you are suspecting if it is an adrenal tumor, and the dictum is if, as Ravishankar sir was saying, 12 centimeter with solid component, invariably there will be malignant lesions. Even if you think it is arising from adrenal,
yes,
less
sir.
likely to be a this one, pheochroma or something of that sort when it is of such a huge size.
Why?
Yes, sir.
What test will you do,
So
Nikita?
Sir,
what?
serum metanephrine and serum cortisol, sir.
Yeah. Why do you want to do metanephrine?
So to rule out pheochromocytoma, sir.
As
And
Niranjan said, it's unlikely, no? Usually you don't
yes,
see, you know, pheochromocytomas of this size, but the thing is there is a small this one that it could be pheochromocytoma, and the major issue is on the table. If you have not done it and if suddenly the patient goes into a hypertensive crisis, then you will
yes,
be
sir.
in trouble. So that is why it is just a simple investigation to do, though the percentage of tumors of this size, especially of no vascularity, being a pheochromocytoma is less likely, but still it is better to do it because it's only a blood test that you need to do, and if it is negative, at least it will put your mind at rest and the anesthetist will be happier. Okay. Serum cortisol.
To rule out Cushing syndrome, sir.
Okay. So the
And
patient does not have any other features of, he's not
no,
diabetic,
no,
he's not diabetic, he's obese.
Obesity, 120
Obesity is
kgs.
there. Is there
obe-
any rashes or anything like that on the body?
no, sir. No other features of Cushing, sir. But he
Okay.
is obese.
Has he got Cushingoid features or he is just obese?
Just obese, sir. Central obesity.
Okay, right.
Yes. And that's it, sir. After ruling out the functional tumor,
His potassium was normal?
Yes, sir. Potassium is normal, sir.
Okay, why did I ask that question? Hypertension, potassium being low, what will you think of?
So Conn syndrome, like hyperaldosteronism, patients can have
Hyperaldosteronism.
hypo.
Yeah. So that is why if the potassium is very low, then you have to think about it. That's all. But generally, these two, Cushing's and Theo, are the more likely to be thought of. Okay. Now, how will you manage this patient? You have all the
yes.
investigations.
After ruling out and stabilizing the patient, we would like to take up for the
What stabilizing? He's
So
already
in case
stable.
if it was positive for pheochromocytoma or Cushing's, but to handle the hypertension initially, sir, like
So that you are unnecessary, see, you are unnecessarily digging at this one because they will go on the tangent of how will you control this patient for pheochromocytoma, all those things. Don't unnecessarily invite questions. If the examiner asks you, you answer it. Otherwise, how will you manage, Andre? You already said that you're going to do
proceed for
metanephrine
surgery.
and steroids, and I think it's unlikely that they will be positive.
At this stage, all you have to say is, if all those workup is negative, what will you do? If one of them
Yeah.
turns positive, what will you do?
Yeah.
All are negative. Now you tell me, what will you do?
Sir, we'll take up the patient for surgery for the excision of the suprarenal mass and to get a histopathological diagnosis, sir.
Okay.
How will you approach this?
Sir, considering the size of the lesion, as per guidelines, anything greater than 10 centimeters, they are usually advising for open surgery because most of it is retroperitoneal and the access is difficult. But it is surgeon's preference. If you're capable, we can still opt for a laparoscopic.
You are the surgeon. What will you do is the question.
I would go for an open surgery for suprarenal mass excision, sir.
Correct. I think that is a safe answer to say.
Right.
Yeah.
Niranjan?
What if one of those metanephrines is elevated, and how will you go about it?
Yes, sir. First, we will start the patient on alpha blockers, sir, selective alpha blockers.
Okay. Why?
And
Why do you want to do
Involve the
that?
anesthetists, involve the endocrinologist from the day it
Endocrinologist.
is diagnosed, so that they are all in the loop and they decide on what tablets to give or what medicines to give, how long to give, how much to give. You are a surgeon.
yes,
Yeah.
sir.
So that is the answer you have to give. But why do you preferentially alpha block before you do beta blockade?
I'm.
So this is why
I
I
forgot,
told
sir.
you,
Yes, sir.
if you don't know the answer, then don't go there because that is
Yes.
smart thing to do. As Rajshekhar said, involve the endocrinologists and physicians and the anesthetists so that they all discuss and treat the patient, get the blood pressure under control, and then take the patient up for surgery. But you're right, preferentially you have to first alpha block and then add the beta blocker. Karthik, do you know the answer?
Sir, alpha blocker, it helps in blocks the excess catecholamine release and reduce the hypertension.
Both do the same thing, beta blocker and alpha blocker.
Yes, sir.
Sanya?
So beta blockers
And
alone will cause
severe vasoconstriction will happen, sir, if you don't block the alpha receptors first.
So what happens if there is severe vasoconstriction?
So hypertensive crisis patient will go into hypertensive crisis.
So you alpha block first and then go for beta blocker.
Yes, sir. Yes, sir.
I think what I would say is I would have given you a more sort of descriptive explanation, but then it will you will forget it. So I want you to go and read up and put it up in the group. Why alpha blockade is preferred first compared to the beta blockers, and then you have to obviously beta block also, and then after the patient's blood pressure is stabilized. So I think another question they will ask you probably is on table, how do you monitor and how do you control the blood pressure? Nikita.
On table, intraoperative blood pressure control. We need to
No. Yeah,
sir?
you tell me how you do it.
Continuous monitoring and IV
How
fluid,
do you
sir.
do continuous monitoring?
Arterial catheter BP
Yeah, arterial
monitoring, sir.
line. So you need to have an arterial line. It is mandatory. So you have an arterial line and you have regular monitoring of the blood pressure, and then how do you control? What is the drug that drug of choice in these situations?
Sir, nitroprusside and phentolamine are the choice of drugs
Sodium
intraoperative, sir, for immediate
sodium,
control.
sodium nitroprusside. What is the precaution that you need to take for sodium nitroprusside? It is photosensitive, so the the bottle or the drip needs to be covered with silver foil so that the drug is not exposed to the light.
Which is the other commonly used antifungal that is photosensitive? Used during COVID.
Come on, man. Anybody?
And there is one chemotherapy drug which is photosensitive, which has to be covered like that. This moment you say photosensitive drug, this is the list that should go through your mind. It can be a question in your theory.
einass?
Amphotericin.
Yeah.
Amphotericin B,
Yes.
and then chemotherapy. Homework.
Okay, you guys read about those things. Yeah,
Homework.
continue. Next. Yeah.
Yes, sir.
Okay. So open is acceptable. If laparoscopy, how will you approach? Shall we ask Karthik? Do you want to take that question? How will you approach? Like this is a right-sided Raj adrenal tumor.
Yes, sir.
How will you approach this laparoscopically?
So laparoscopically, we place the patient in a left lateral position first, and we place a ports like a 10 mm port in the mid clavicular line at the umbilical level, and working ports 5 mm will be placed, one in the mid axillary line and one in the right hypochondriac region.
How many ports do you need?
So, one camera port and 3 working ports required, sir. On the right.
Minimum three working ports and a camera port. Sometimes
Yes.
you might need another one for what?
For liver retraction.
Liver retraction.
Yes, sir.
Right. Then what will you do? What is the first step?
The first step is to we have to release the hepatoduodenal ligament. We have to mobilize the duodenum, sir.
Why do you want to mobilize duodenum, man? You have to mobilize what?
This one, sir. Hepatic flexure of the colon, sir.
Hepatic flexure, not
Yes, sir.
duodenum.
Yes, sir.
So hepatic flexure you have to mobilize, and even the transverse colon, the whole thing it falls up. The patient is left side, right side up, and maybe head end elevated.
Yes, sir.
And once the hepatic flexure and the right colon, drops down, then
Yes,
what
sir.
will you do? Nikita?
Sir, now we mobilize the duodenal segment, sir, over the gyrotous fascia and enter the gyrotous fascia. By then, we would have found the mass, sir.
Usually, how do you differentiate the fat in there compared to the mass? This will be generally the adrenal mass will be
Gold shine, yes, sir.
golden yellow compared to the pale yellow of
Pale
the
yellow surrounding gyrotous, yes, sir.
And then what is the most important step in this procedure? Generally, after you mobilize.
Sir, vascular ligation or disconnection, sir.
Of what?
Either the adrenal or the vascular supply of the lesion.
The most important thing is the adrenal vein.
Yes.
Where does it drain?
Directly to the IVC, sir.
Correct. So
Right adrenal vein, yes, sir.
the right adrenal vein is what compared to the left adrenal vein?
Very short and drains directly into IVC, sir.
Correct. So it is very short. So you have to be extremely careful because you don't have much to play with. So if you, while you are working medially, if you are a bit careless, you might rip it off from the IVC and then you will have catastrophic bleeding. So you have to be extremely careful. On the left side, because it has to cross the midline, the left adrenal vein is a bit longer. So you will have a reasonable length to clip. Here you have to be extremely careful to mobilize this and find the adrenal vein. Arterial bleeding is not an issue because you can just put pressure over it and it will stop. But venous bleeding, especially from IVC, is very troublesome and it will continue, so that you will be in big trouble. So which is why you have to be extremely careful. So after you mobilize the whole thing, you have to identify the vessels and clip the thing. Usually use a hemolock clip, and then after you have separated it and you put it in a bag and take it out. Same procedure with open also. The important steps are to mobilize the hepatic and the right colon, hepatic flexure and the right colon, and then mobilize the duodenum a bit medially, enter the gyrota fascia, identify the tumor, gently dissect it using vascular bipolar or whatever is one energy source you have, and then identify the vessels and clip them and then take it out. So you have to, again, the anesthetist have to be aware, continuous blood pressure monitoring and everything. Even though you might have this one, you might have found that the metanephrines are negative, still you have to presume that sometimes it may be a functional tumor. You better be on the guard. Post-operative complications, Nikita.
Sir, first would be the hemorrhage or hematoma, sir. Considering the vascularity and the intraop ligation.
Okay.
And as a hypertension, we have discussed, sir, if release of catecholamines, if it happens, even post-operative hypertensive crisis can occur.
Then what else?
These are the specific ones, sir. Routine surgical complications.
No, routine, you tell us, what are the things, for example, subphrenic collection can happen. You can have, because you're operating in that area, you can have,
Yes, sir.
atelectasis pneumonia, DVT, all of these things.
Yes.
Don't limit yourself to this. You have to, when you are asked about post-operative complications, list out everything. He's an obese man, so he can have DVT.
Yes, sir.
He can have atelectasis pneumonia, all of these things, and then wound infection.
Wound infections.
Okay.
Okay, next case.
Next case. Niranjan, any questions? Rajshekar, any questions?
What was done for this case? Was it managed or yet to be managed?
ಇಲ್ಲ, it posted for tomorrow.
Okay, laparotomy.
ಇಲ್ಲ, ಇನಿಷಿಯಲ್ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿಕ್ ಅಪ್ರೋಚ್ ಅಂತ ಹೇಳಿದ್ದಾರೆ. And then with the very low threshold to convert if it is necessary.
ನೀವು ಮಾಡ್ತಾ ಇರೋದಾ?
ಅಲ್ಲ, ಇವರು ಸಾರ್ ಕೇಸ್ ಆಲ್ರೆಡಿ ಸರ್. ಹೌದು.
Okay.
Rajshekar, any questions?
No, that's definitely interesting case. Let's see. Yeah.
Okay. Yeah. Go for the next one.
Yes, sir. This is a case of a 56-year-old female who came with complaints of loss of weight and generalized weakness in the last 9 months. She is a known case of solitary fibrous tumor, which was there over the right pleural base, and for which she had undergone right thoracotomy with the excision of the right pleural base tumor. After which she was not very consistent on her follow-up. This was done 9 years back. And now, in the last 3 months, she developed complaints of loss of weight of around 3 kgs and complaints of generalized weakness in the last 9 months, since the last 9 months. Apart from this, there's no complaints of fever, cough, hemoptysis, breathlessness, chest pain, abdominal pain, or any altered bowel bladder habits. She's a known case of hypertension on treatment and status post right hemithyroidectomy for goiter 9 years back. Status post total abdominal hysterectomy and open tubectomy, which were done 25 and 20 years back, respectively. And on clinical examination, she was hemodynamically stable. The systemic examination also was normal. On the right chest wall, the lateral aspect, there was a posterolateral thoracotomy scar which was seen. Uh, After these, again, routine investigations done were as follows, which were within normal limits. And
How
the
old is this
patient
lady?
had,
Sorry. How old is this lady?
so she's 56 years
56.
old.
Okay.
Yes. After this, the patient had undergone PET-CT, which showed that there were multiple discrete prominent solid masses, nearly 6 in total, which were noted along the pleura bilaterally, more marked on the right side, and the largest was right side basal pleura, and the largest was measuring around 9 cross 9 centimeters. These masses were noted to cause significant indentation over the mediastinal structure and the liver by the pleural lesion. And there was a non-FDG avid 14 nodule, which was noted in the apical segment of the left lung lower lobe as well. A few subcarinal bilateral axillary lymph nodes and right paratracheal lymph nodes were noted with low-grade tracer uptake of around SUV of around 4. Uh, After this, the patient underwent the surgical management, wherein a clamshell incision, that is bilateral anterolateral thoracotomy and sternotomy was done, and followed by excision of multiple metastatic tumors. The tumor, there was a large tumor which was noted to arise from the left lung uh, lower lobe. And apart from these were the nodules which were noted, which were arising, sir. Like this, I directly went into the management part, sir. Should I?
Curiosity would have been when you have bilateral big masses, how do you approach and etc. etc. But you already gone into management and describe the management. Stop there and see if anyone has any questions,
Yeah.
any different
Yes, sir.
opinion or different ideas, or any questions.
Sir, what we were thinking is, as per the PET-CT, there are multiple mass which are seen. Most of them we are suspecting to be probably recurrence of tumor.
Yeah.
So, in the treatment part, sir, are we planning for an R0 resection, or
Principles
is it
of
palliative?
metastastectomy, especially the pulmonary metastastectomy, is when there is no recurrence in the primary tumor bed, no mets elsewhere in the body, and preoperatively you can do an R0 resection. Only, and at the end of multiple metastastectomies, there should be adequate pulmonary reserve and adequate cardiac reserve for the patient to survive. All these criteria have to be fulfilled before you consider metastastectomy. Now the question comes, why did we use a huge moribund clamshell incision in this patient?
Yeah.
What other approaches you had? Any
Raj,
ideas, any thoughts in this?
Raj, can I just interrupt?
Yeah.
This few subcarinal bilateral axillary nodes, though they are low tracer uptake, are they of any significance to you? Do they make your decision making any different?
This patient was referred by the oncologist in Sakra Hospital. We had several rounds of MDT discussions there and etc. Lymph nodes were considered insignificant.
Insignificant, yeah.
Because solitary fibrous tumors don't spread to lymph nodes. But anyway, we have taken out the paratracheal and subcarinal lymph nodes. We are yet to get the histopathology.
Yeah.
Any difference in opinion as to how to approach this patient surgically? We also had an opinion about preoperative CT-guided biopsy to prove it as a spindle cell tumor. Then the mitotic index, which was very low, meaning to say that they are not going to respond to chemo or radiotherapy. There was a thought process of neoadjuvant treatment and then surgery, which was again went through the MDT, and then they said, no, you go ahead with surgery. Patient
Sir,
has
any role for this imatinib or monoclonal or
all,
biologicals in these cases?
all that is discussed. Solitary fibrous tumors do not respond to any kind of
Yeah.
treatment. If this patient, if she had high mitotic index, they would have tried neoadjuvant like immunomodulating drugs. Even that was low. So finally, it was sent for surgery.
Okay.
So I think
Any
now
role for thoracoscopy, excision?
Tumor is largest measuring is about 10 centimeters.
Okay.
So you can't do thoracoscopy excision. Number two, the recurrence or primary was in the right chest, and there is the recurrence, which is you
Okay.
expect it to be adherent to all the major blood vessels. As it happened in this case, right side one was we had to strip the pleura with the phrenic nerve from the inferior vena cava, and we couldn't get the plane between the diaphragm and the tumor, so we had to excise the part of the diaphragm and then repair it. It was a difficult case, and the left one was nearly lung based. PET scan had described all of them as pleural based. To the surprise, on table, left one were all in the lung, right one were all in the chest wall on the pleural based. And the biggest was in the cardiophrenic angle, stuck to IVC, stuck to inferior pulmonary vein, stuck to the diaphragm. Who was there at the time of surgery?
Me and einass, sir.
Do you have any idea why I stood on the right side and I allowed you to stand on the left side? Was that a deliberate decision or just accidentally happened?
Because right side was the recurrence side.
Yeah.
Yes.
Correct. You are right.
Right.
And that's where the original description of the tumor was also attached to the diaphragm pleural base. That's where the largest recurrence on the right side. That's where the bleeding happened at the time, tumor vessels.
Yes,
It
sir.
took some time
Yes,
to
sir.
struggle to
Yes.
find and control it.
So couldn't we have done bilateral only thoracotomy, sir, like instead of complete midline?
Yeah, you have to put her into one lateral position, open and then close, and then another lateral position, which will take at least 3 hours on each side. You will be operating for the whole day. What is wrong in this position, which you could have simultaneously, you can access on the both sides and then get a good access and clearance.
Yes, sir.
Are there
And
any
sir,
questions?
so like solitary fibrous tumors in general are slow growing tumors,
Correct.
and like they take a lot of time to manifest. So is there a role of not operating at all in this case, like to consider not operating in a patient? When do we do that, sir?
Reasonable size tumors, nearly 10 centimeters on either side. One is pressing on the inferior vena cava, pericardium, and the heart. Invariably, it will have pressure symptoms. What symptoms she is complaining now are the pressure symptoms. So left untreated, unresected, she will rapidly deteriorate. I think that's where she came to the picture. 9 months of symptoms. Now she come to the hospital. So there was no other choice but to operate.
choice, and this is
Now,
not
now, what will be the prognosis, sir, regarding recurrence or?
In fact, right side, left side, all R0. Right side, it's not R0 because, like I said, the largest, about 10 into 12 centimeter, was stuck to the cardiophrenic recess with the IVC. Like I said, we had to excise, go inside the capsule, excise the tumor, and then excise the capsule as much as possible. So there is a little bit of capsule on the IVC, that cardiophrenic angle where there was bleeding. I didn't know what was bleeding from. So that part she needs, we have marked it with clips, and that needs some amount of radiotherapy to that region. How she is going to respond or not, we don't know. But it's a continuous discussion between the oncologist in Sakra Hospital and us.
Okay.
Have you read about clamshell incision, hemiclamshell incision, and other incisions in the chest?
anybody?
Yes, sir.
Yes,
But
sir.
Einass and Nikita, you were there. What is hemiclamshell incision?
that involves sternotomy and lateral thoracotomy, sir.
And when will you use it?
If pericardium is involved, sir.
Yeah, go on. Yeah. Large
And
tumor
in
with pericardium, major vessels being affected, or we want access both proximal and
anterior
distal to
medial
the
space.
subclavian vessels. You need like a book flap type exposure, entire clavicle, part of the sternum, anterior chest wall exposed so that you can access to the subclavian vessels and both proximally and distally. Typically used in Pancreas tumors. Okay.
What is full clamshell incision?
You know?
Full clamshell.
Bilateral,
Bilateral.
sorry, bilateral
Bilateral.
anterior
Yeah.
lateral thoracotomy with
And cut the sternum
sternotomy.
along the line of your thoracotomies.
So what happens to this one, the Rima and Lima?
Both will be sacrificed.
So
Both
she
will be
will not
sacrificed, so you cannot think of using them for
using them
graft in the
for
subsequent
CABG in
CABG.
future. Yeah.
Yeah, these are the patients whom you don't expect to survive a normal lifespan.
Yeah. Okay.
Even if they survive a normal lifespan, and then if they require a bypass, then the options like using a radial
Saphenous
artery or
vein.
a saphenous venous graft,
Saphenous vein graft.
Lima, Rima, both will be sacrificed.
Sacrifice. Yeah.
Yeah. What do you mean by Lima, Rima, einass?
The internal left and right
Both
internal
internal mammary.
mammary
Left
artery.
internal mammary is the commonly used graft for the arterial graft to be anastomosed to the left circumflex artery. Once you cut these two vessels, the typical question, if the patient survives long enough to have an MI and can't be sorted out by PTCA and needs bypass, where will you get the graft from? That was his question, Ravishankar's question. In what other indications can you use this incision?
Uh,
Uh,
mediastinal tumors are anterior and
Large posterior mediastinal or anterior mediastinal tumor which is extending onto the both sides. And in a patient which has bronchiectasis in the lingula and the middle lobe and bleeding, hemoptysis, you are not sure which side to operate and you need to address both of them at the same side. There are very few indications for this large incision.
What is the einass? What is the significance of Rima and Lima?
uh, so they are primarily
Origin.
you see so the left side originates from the left ascending anterior descending artery, sir, and
I,
No. What is
I,
happening?
no, sir,
internal
no, sir.
mammary
Wait,
artery is
it is
asking.
linked. Uh,
What are
No,
the branches of
is
first part of subclavian artery, second part of subclavian artery?
so yeah, so one minute, I forgot. So,
Subclavian directly from the aorta, lima coming from the first branch of the subclavian has a high output, high flow, gives the one of the best conduits for a coronary artery bypass grafting.
and for some reason it is very less prone to developing atherosclerosis. So
Because of the high pressure flow.
high pressure flow. So that is why it always gives you a very good conduit, and also the graft is less likely to occlude. Okay.
Anything else?
So what are
the
how,
amount of morbidity associated with clamshell incision, sir.
what is the morbidity?
So first and foremost thing would be the pain, sir.
Pain, correct. So how will you overcome that? Did they give anything?
So in this case, epidural was
Thoracic epidural. You should specifically
thoracic
Correct.
epidural. Yes,
Correct.
sir.
Correct. Yeah.
thoracic epidural. Then
And
Because you're cutting on both these
physiotherapy.
sides, bilateral basal atelectasis, pneumonia, all those
pneumonia, all
complications
those
are a
things
much
are there.
higher level. And because you are cutting both internal mammary arteries, sternal dehiscence, wound infection, non-healing of the sternal cut are again common complications.
Yeah.
Just because we are lucky we escaped without any such complications in this patient doesn't mean it is without complications. Okay?
Yes, sir.
Anything else?
Mm. Is it any different from the recovery time, sir, from a normal thoracotomy incision or to that surgery to the complete clamshell?
I
We'll
don't
be
think so.
waiting.
I
Obviously
don't
it
think
will
so.
be.
I don't think so. Yeah.
The
The real
histology.
question you should ask is, somebody, I was expecting someone to ask, could we have approached it by a sternotomy?
I
You needed
wanted to ask
access to
that
both
question.
pleural cavities. Could we have done it by a proper midline sternotomy rather than a bilateral anterolateral thoracotomy?
I wanted to ask the question, but I thought because the tumor is, quite extensive below, you may not be able to get the access
Yeah.
with
If you do
the.
a midline sternotomy, you get the best access to the anterior part of the pleural cavity structures. Posterior paravertebral, it is almost impossible to
Possible.
access or clamp or do
Correct.
something about it.
Yeah, yeah.
So I was left with no other choice but to do clamshell incision.
Yeah.
Okay.
Histology ಇನ್ನು ಬಂದಿಲ್ವಾ ರಾಜಶೇಖರ್?
Preliminary report, it's a spindle cell tumor andidare, but they wanted to do immunohistochemistry and they wanted to look into the lymph nodes. Innu release ಮಾಡಿಲ್ಲ report.
This is a different tumor compared to the original one.
I think it is the same.
Oh.
It is the same. Original tumor was nearly 4 kgs or 4.5 kgs excised by the oncosurgeon through a big thoracotomy. And she survived for this long because it's a solitary fibrous tumor. That's all.
Okay.
And hopefully she survives for at least another 5-6 years, if not 9-10 years.
Okay. Right.
Okay,
Next
guys,
case.
any questions?
Niranjan, any
So
questions?
so it's mostly like buying time for her only, sir. Like in case if recurrence
No,
happens
sir.
also, we're going to excise it.
Generally, solitary fibrous tumors, we really don't look for recurrence. Once you excise it and it's the end of the story, very rarely you get a recurrence like this. When she had a recurrence of nearly 4 nodules on the left lung and then 4 nodules on the right side, 1 in the 2 in the pericardium on the lateral chest wall, do you not expect it to come back?
It
It
might,
should
sir.
come back. It should come
Yes.
back. Common sense. Question
Yes.
is how quick or how slow? Okay. It's only
Yes.
time will answer what good we have done to this patient. Like I said, if she survives for 4-5 years without symptom, even if there is a recurrence, if it does not cause any symptoms, that's a good achievement. That's all in this patient.
Rajshekar,
Yeah.
these PET CT nodules in the lung and this one, were they taking up this one FDG PET or not?
FDG PET only was done, and then they all said they all are pleural based. They had counted total about 6 lesions on the PET scan, and 2 on the right side, 1 on the left side. We found a big nodule on the left side in the attached from the left lower lobe, and there were 3 smaller nodules in the upper lobe surface. So totally 4 from the left side. Right side, they described 2. 1 on the pericardium about 2 centimeters, 1 big about 10 centimeters at the cardiophrenic angle, and then 2 in the lateral chest wall, actual chest wall on the pleura.
Yeah.
It's a very peculiar. On the site of primary tumor, it's all on the pleural based. On the opposite side, as if it's a hematogenous metastasis only in the lung, not the pleural base.
Okay.
So
were they
I
taking
don't
up
expect her
FDG?
to go recurrence free few years down the line.
Were they taking up FDG?
Yeah.
So in that case, maybe they will be responsive to chemotherapy or something.
Yeah, post-op analysis and the oncologist will take a call.
Yeah.
Radiotherapy to that area in the near infia vena cava where we have put clips to the capsule, and then whether she needs immunomodulating or chemotherapy, I think oncologist will, Satish oncologist from Sakra, he will take a call. Yeah.
Okay. Right. Okay. Let's move to the
Okay.
last case.
Move on. Yeah.
Quickly.
So there were only 2 cases, sir. The third one actually just recently operated. I'll just verbally tell the history,
Yeah.
sir. He's a 75-year-old male. He came with complaints of swelling and pain over the right groin region since the last 6 to 7 months. So since the last 6 to 7 months, initially he had a swelling over the right groin region, which was initially reducible to begin with. But in the last 4 months, he noticed that the swelling is
So
extending till the
this is not a
scrotal.
clinical presentation, ma. You just present it.
Yes, sir.
So what is it and what because this is about ward rounds. So it's not a clinical case discussion. Okay. So it
Yes,
was
sir.
a bilateral inguinal hernia.
Sir, right side inguinal hernia, inguinoscrotal hernia with
Ah,
bowel as content, and on the left side there was cough impulse which was present, sir.
okay.
Apart from these, the patient had multiple comorbidities. He had a recent history of IHD. He was status post PTCA, which was done last year in September. And apart from that, he was on still presently on blood thinners, ecosprin and ticagrelor, and he was a known diabetic. Uh, and on yes, sir,
So what is this?
so
How would you approach it? First of all, so September to now January, uh, would you consider operating or would you wait till beyond 6 months or so where the risks are lower, or will the patient symptoms warrant immediate surgery?
It is based on the patient's symptoms, sir. Because the patient was having pain and there was a risk of based on the patient's symptoms is when we'll consider operating, sir. And as we see that bowel is the content in the uh, of the hernial sac, sir, we should consider operating, sir, before he lands
So,
up in obstruction.
so clinically was this reducible, not reducible,
Not reducible, sir.
and was it tender? Was there
Tendon.
danger of obstruction, strangulation?
Yes, sir. Tendon. So actually, sir, the patient had come so he was operated recently, but 2 weeks before this, he had come to the emergency with complaints of severe pain, and at that
Pain.
point, tenderness was there.
Okay.
So that is when the decision was made that to consider operating on him because there was a risk of obstruction and this.
Yeah.
But now, when he came at this presentation, it was non-tender, sir.
Okay.
Like
But the
post
important
5 days of.
thing is, what all of you have to understand is whether it is ischemic heart disease, coronary artery, acute coronary syndrome, or a CVA, all of those, high risk situations, it is safer to wait till about 6 months at least for the risks of that particular person to return to his pre-incident risk. It will not be equivalent to somebody who is otherwise healthy. Obviously, if there is a patient who is 60 who has no ischemic heart disease, and if you look at his risk and compare to this person who has had a ischemic heart disease MI and needed CABG or coronary artery stenting, so his risk before the incidence, whatever it was, it will return to that. So if possible, wait for 6 months. But if the patient is very symptomatic and there is a potential for obstruction and strangulation, then you have to explain the risks to the patient and then operate on them. So what are the precautions you take in terms of, because he's already on anticoagulation, you have to obviously consult the cardiologist. So what are your questions to the cardiologist, Nikita?
Sir, bridging the antiplatelet therapy, sir.
Correct. So what will you do? What did they advise?
So usually they advise on stopping the oral anticoagulants which are going on and
Ah,
convert it to low molecular heparin, sir.
correct. Okay.
At least for 3 days if it was ecosprin, and 5 days for clopidogrel.
Clopidogrel. But he is on I think rivaroxaban,
Yes, sir.
No, sir. Ticagrelor
Ticagrel.
ticagrelor. Okay.
and ecosprin.
Ecosprin. So you have to bridge with the heparin, more low molecular weight heparin. Okay. Now, how old is this gentleman?
So
He is
he's
58-year-old.
Ah. So how will you approach this, Nikita? Laparoscopy or open? Bilateral hernia.
Sir, if I were to operate with my expertise, I would actually go for open surgery, sir, because it's non-reducible.
Okay. Then, and what else? That is one, not non-reducible. Second one,
Large inguinoscrotal hernia,
Yes,
sir,
correct.
long
Then
standing. And it also has bowel as a component, like sliding component also.
no, that is not, no, that will not decide whether it is open or laparoscopy. But other two, whatever you said is right. What is the third most important thing?
Patient's general condition to tolerate general anesthesia,
General
sir.
anesthesia. So if he's had a recent coronary artery disease, you probably would go for a spinal rather than a general anesthesia. So for these reasons, but if you consult the anesthetist and if they are happy with, sometimes you can't have a very strict thing. If they are happy, if the patient is stable, they may opt for general anesthesia. So that depends on the expertise of the treating team and the surgeon and the anesthetist. So, but your answer is correct. At your level, the experience, it is safer to do an open procedure. Okay. What was done?
Sir, laparoscopic approach was.
Okay, go on. Hello.
Hello, sir. Can you hear me, sir?
Okay, I can hear you.
Sir, laparoscopic approach was attempted, sir. But patient could not tolerate general anesthesia for. So in that aspect,
No, it was not. He could not tolerate. See, two things here. Patient had irreducible inguinal hernia on the right side, and he had direct hernia on the left side. So here the consideration was whether patient is fit for anesthesia in the first place, and whether we can operate so soon after the cardiac event. What the cardiologist said is current recommendation is 3 months. After 3 months of stenting, if patient hemodynamics are stable and his cardiac functions are okay, you can go ahead if the patient is symptomatic. He had impending episode of one strangulation. He had come with acute pain 1 week or 10 days back. So we had referred him to cardiologist to take the opinion. So currently his cardiac status was almost EFS around 48%, and he did not have any other symptoms. He was well preserved, and he did not have any other significant morbidity where we had to refuse surgery just by looking at him. So the cardiologist said he is low risk at this point of time, but he wanted a bridge therapy because it was 4 months. So he had put him on Clexane. So currently, when we attempted laparoscopy, there were large bowel loop. It was not small bowel; it was a large bowel loop. That too, it was not a sliding hernia. The entire loop was gone and stuck. It was a chronic. It was not an acute impaction, but the entire loop of sigmoid colon along with the fat was stuck inside. So that's why he was having symptoms. And when we attempted, that was not reducible. So what we decided to do is complete the left side and then go in for an hybrid incision. Why we considered laparoscopy in this case was, one, they said he's fit for general anesthesia. Two, he was on dual antiplatelet. So when we open and do, and that too in a large hernia, there is a possibility of hematoma and seroma formation because of antiplatelet, even if you would have stopped for 5 days or 7 days because of the because of the open surgery. So that is why we considered laparoscopy. So now what we did was we were doing the hybrid thing. We opened up the sac, pushed in the colon, and we are about to proceed with placing the mesh on the right side. At that time, he had hypotension and this thing. So hypotension and bradycardia. So CPR was done, and then we got the cardiology. Then they said we cannot proceed till the cardiology evaluation happens. So cardiologist came in and we shifted him to ICU. Like in between the surgery, we abandoned and closed the incision. So then what they saw was he had developed fresh ECG changes which were not there in the previous ECG. We already had previous when he had previous surgery. He also had I think he had circumflex this thing which had blocked. They had put a stent into that. The other one they had noticed a block, but they said since he was not symptomatic because of that, they had left it with the antiplatelet. So that one had given him trouble now. So that is why they said, okay, they had to do an emergency angioplasty because he has developed fresh changes. So what we did was once the patient was stabilized and his BP came up and he became conscious He was responding. So after that, what the combined decision was to take him up again and finish the surgery, because only the part of the mesh had to be placed, and tackers had to be it had to be closed with tackers or sutures. The flap had to be closed on both sides. So that was done. And again, after that, he had to be taken up for angioplasty, and they stented him. So these are the two things. So that was the consideration for doing laparoscopy. Because he was on dual antiplatelet and possibility of bleeding and seroma was very high.
Oh, good. Both procedures have been
And
done.
because pre-op cardiac parameters and pre-op evaluation and the cardiology evaluation, they said he's fit for GA. That is why we went ahead with laparoscopy, because it was bilateral, and since there we would have involved a large amount of dissection.
Niranjan, one question is, because of all these things, could you have ignored the right direct hernia and dealt only the left one?
Sorry, sir.
Because of the
Hello?
cardiac risk and etc., could you have ignored the right direct and
Hello?
deal only the left one by open procedure? A question ಬರುತ್ತೆ.
ಅಲ್ಲ ಕೇಳಿಸಿಲ್ಲ ಏನ್ ಹೇಳಿದ್ದು.
ಅದೇ ಈಗ ರೈಟ್ ಸೈಡ್ ಈಸ್ ಇದಲ್ವಾ, he had a large right sided, left side was a small direct hernia.
ಇಲ್ಲ, ಲೆಫ್ಟ್ ಸೈಡ್ intra-op it was a pantaloon hernia, left indirect as well as left direct.
ಅಲ್ಲ ಸರಿ, but could you have left it alone, considering the high risk the patient was in, just to operate on the symptomatic side ಅಂತ? That is the question.
ಕೇಳಿಸ್ತಾ ಇಲ್ಲ, ವಾಯ್ಸ್ ಬ್ರೇಕ್ ಆಗ್ತಾ ಇದೆ.
ಅಲ್ಲ ಇದು why did you consider just operating on the symptomatic side and leaving alone the other side to consider that later once he is more stable?
That option we had discussed with the patient attender. So they wanted that also to be done in the same setting. Because the cardiologist had given fitness, they said because we can't bring him up again and again, since he's fit anta ಹೇಳಿರೋದ್ರಿಂದ you finish it off anta.
Okay.
That option was discussed with the patient family. Patient ivaga is getting extubated.
Okay.
He is on TPs.
Okay, good.
So the lessons here for all of you is that one, as Niranjan said, though the current thing is 3 or 4 months, generally, the rule of the thumb is 6 months. If the patient is very symptomatic and it has to be done, then you take a proper cardiac evaluation, cardiac fitness, and then follow their advice, and then anesthetist has to decide whether the patient is fit for general anesthesia, because cardiologists are not going to give the anesthesia. Anesthetists also have to be involved. If the anesthetists are happy to give him general anesthesia, only then consider doing laparoscopy. Otherwise,
Correct.
You can do a open procedure for this hernia, and then because I think the thing is, a hematoma or a seroma is a less of an evil compared to the possible complications you can have with general anesthesia. So that is what you have to weigh against. So, but everything is you have to patient specific, customize it to the patient's condition and patient's heart and other whatever comorbidity he has. Any questions from the students?
No, sir.
Okay, if there are no questions, I think we've had a fruitful discussion of 3 cases, and if there are no questions, we will stop the meeting. And thanks to Ravishankar and Niranjan and for all of you to attend.
Good discussion, good presentation. Thank you. Good night.
Good night.
Yeah, bye.
Thank you, sir.